So I'm delighted to welcome Professor Michael Jenkinson, who's Professor of Neurosurgery in Liverpool, and as many of you know, does lots of trials in neuro-oncology. So he's going to talk to us about meningiomas. For those of you who haven't been to HIN talk before, we have about 45 minutes of talking, and then we try and cut the speaker off so that we've got at least sort of 10 to 15 minutes to ask questions. Michael, please share your screen and take us away.
Just to let you know, we will be recording this session, so please let me know if you've got any issues with that. And for those who join later, we will make this available at a later date on our webpage.
Great. Well, thank you, Matt. Thank you, Lily, for inviting me. Good evening, all. Let me see if I can make this work. Hopefully that's in presenter mode. Great. Okay, so so I'm going to talk about meningiomas, and I'll just run through a few fast facts just to cover the audience breadth, because not everyone here is a medic or not necessarily an expert. But meningiomas, these are the commonest brain tumors we see. About a third of all brain tumors, and they're a tumor that we see as people get older and more common in females than males. They can have all sorts of appearances, from very large tumors to very small tumors. They have quite specific appearances or well-characterized appearances on MRI, so they can look like large lumps of rock in the brain. And they can cause lots of swelling and pressure on the adjacent brain. So they can have a variety of appearances. And they can appear anywhere within the skull. Most of them tend to appear on the skull vault, so on the upper surfaces. But some of them will occur down near the skull base and be entangled in nerves and blood vessels. Occasionally they appear in the spine, and extremely rarely they can metastasize to other parts of the body. We know there are certain risk factors, so radiation during your lifetime, particularly in childhood, is a risk factor. Having neurofibromatosis type 2 is also a risk factor. And we know that certain hormones, if you have meningiomas, will cause them to grow. Particularly seen in pregnancy, and those meningiomas will then shrink as the pregnancy has finished. They've been around for a long time. The WHO keep changing how they classify them, but essentially it's become a little bit more complicated. We know a little bit more about the genetic mutations involved, and as a result of this, the pathologists will now diagnose more of the grade 2 meningiomas, a slightly lower diagnosis rate for grade 1. But the grade 3 meningiomas, those malignant or anaplastic tumors, the diagnosis rate remains low at around 1 or 2%. So that's just a rapid run through of the background of meningiomas. So why are we interested in meningiomas? Well, when I was training, it was really considered a benign neurosurgical disease. Certainly as a trainee, I loved operating on meningiomas. And, we can look at pictures like this as neurosurgeons, these tumors in various parts of the brain. And we can all put up scans afterwards showing how marvelous we are at taking these tumors out and allegedly curing people, and all is great. However, just being able to put up nice before and after pictures is a little bit orthopedic in approach. Here is a bone, I fixed it. Here is a tumor, I have removed it. And that sort of misses out on the point of the impact that these meningiomas can have on patients and their carers. And we know, if you look at the quality of life in these individuals, that they can have a long-term impact on their quality of life. And in fact, some of the outcomes in terms of fatigue and cognitive issues very similar to those that we see in those exceptional responders, or those long-term survivors of people who have glioblastoma. So they do have an impact on people's quality of life. We've done our own studies looking at both operated and incidental meningiomas. And it's interesting, the determinants of quality of life that came out were quite clear. But, just having gainful employment after treatment for your meningioma, or having a slightly higher educational level, led to a better reported quality of life in these individuals. So when we got into this, we thought we were doing something new and novel, but then obviously you just go back and read the old textbooks or read the old literature. And this is Harvey Cushing on the right, who wrote a treatise on meningiomas. And then this is the paper from a chap called Donald Simpson, who was actually an orthopedic trainee, who wrote up this big study about meningiomas and really said that, we think these are benign and we can take them out, but some of them do recur. And we really ought to understand a bit more about the biology of these tumors. He described a way of predicting the risk of these meningiomas regrowing, depending on how much tumor we took out, or bone, or the linings of the brain, and came up with this Simpson classification that's still used today, even though this was designed before the advent of CT or MRI. And as you can see, depending on how much you take, depends on your Simpson score. So a score of 1 is better than a score of 5. And that still, to this day, will predict the risk of your tumor regrowing. And the WHO pathology grade, again, will still predict your risk of the tumor regrowing. And that's still what we use in day-to-day clinical practice. So 60, 70 years on from when it was described, that's what we're still using. There are various guidelines produced. This is just the guidelines from the European Association of Neuro-Oncology. It doesn't do anything clever. It doesn't say anything particularly clever in these guidelines. It groups them and says, take everything out if you can possibly do that. Sometimes we may need to use radiotherapy, and it sort of lumps everyone together, even though meningiomas are have a wide range of appearances and sizes. And some of them are symptomatic and some of them are not. And so you end up with a bit of a monopoly if you have a meningioma. So you can have a very small meningioma, such as this one here, and the patient had surgery, but has had horrendous side effects, complications from surgery with a huge amount of brain swelling. And when you're looking after people with meningiomas, it's not just about making a nice post-operative scan or about getting people to live for a long time with them. It's about having a short, medium, and long-term strategy to try and optimize treatment and optimize people's quality of life. So on the back of this, we set up a research program in Liverpool trying to address some of those clinical uncertainties and how best we manage our patients with meningioma. So this is where we come to the good, the bad, and the ugly. We sort of describe the incidental asymptomatic meningiomas in the good group. We talk about the bad meningiomas in terms of harms from our treatments that we offer and how can we optimize that better. And then the downright ugly ones are those very clinically aggressive meningiomas for whom we run out of treatment options and for whom, sadly, those people will die from their highly aggressive meningiomas. So let's talk about incidental meningiomas to start off with. So these are an increasing problem. The ubiquity of CT and MR imaging for a variety of reasons these days, minor head injury, tinnitus, dizziness, people getting MRs for all sorts of reasons. And it coined this phrase called VOMIT, so victims of modern imaging technology. And this causes a huge amount of anxiety for patients. And what do you do with these small meningiomas that you find? And the patient really wants to know, does it need treatment? And if it doesn't need treatment, will it ever need treatment within my lifetime? So you can get into particular scenarios. So I'll just give you a couple of case examples here. So this is a small meningioma in a 35-year-old dentist. And quite rightly, she said, I don't want any treatment whatsoever. We monitored that for 12 years. And in 2022, it was slightly bigger. And then she told me she'd been diagnosed with a leiomyosarcoma. Interestingly, she's actually responded to treatment and is still alive to date. And I'm still monitoring her just because it makes her feel better that we're keeping an eye on the tumor. But she's avoided that harm of any treatment for a dozen years now. If you can contrast this to another case, another meningioma, this person banged their head on a garage door. There's the bruise on the scalp, had the scan, found a meningioma, but was absolutely crippled by the fact that this was in her head. Really wanted treatment for it. Even though we said it's causing no problems, we could monitor it. You don't need treatment. We could leave it alone. And sadly, on taking this tumor out, this small draining vein was affected by the tumor and taken, and they developed post-operative swelling and bleeding, developed seizures after surgery. And although the tumor is taken out and cured, in effect, remains with neurological symptoms 6 years down the line. So when you see these patients, you really, my feeling is that it's important to see them face to face or on a video call, because it often causes a lot of anxiety for patients, and often managing that expectation can help you manage the patient's ongoing care. What we've done in Liverpool is look at all our asymptomatic and incidental meningiomas. And this is work done by my MPhil student, Abed Islam, who's now a trainee in Manchester. And we sort of ended up splitting these into what we call the showers and the growers. So the 90% of meningiomas that we find tend to remain static. We know they must have grown from a single cell at some point, but once you find them, they tend to have this static period. And then about 1 in 10 of them we find tend to continue growing at the point that you've discovered them. And using this, we tried to work out a more rational way of monitoring them. So instead of doing yearly scans for people with incidental meningiomas, to try and split them into low, medium, and high-risk groups, so that you could rationalize, or rather optimize, the frequency of scanning that you needed to do. We developed a little risk calculator. This is freely available online for people to look at. And it takes into account not only the imaging, but also the patient characteristics, comorbidities, other medical problems, to work out what your monitoring strategy should be. This is currently been validated as part of a large international retrospective cohort study. This study is now completed and the data have been submitted to EANO and hopefully will be presented at EANO in Glasgow in October this year. We have to remember when we find these small meningiomas that there are many drivers for treatment. So within the National Health Service, we are able to provide active monitoring for patients, and that's actually the recommendation for the majority of meningiomas. And it allows us to capture that natural history data and avoid the need for treatments that may cause harms. But if you're in a different healthcare system where you are insurance-based, or where the clinician gets paid, you get paid, the more you operate, the more you treat, you may have different biases in deciding how to treat people. And we provided our incidental data to part of this larger study, which was a consortium of people with gamma knife radiosurgery centers in North America. And they looked at, they compared their data set of about 700 cases, I think it was, 800 cases, compared to our monitored data set. And although the neurological outcomes were the same, so the same risk rate of developing neurology with a monitored meningioma as that from giving an upfront treatment, understandably, if you give gamma knife or radiosurgery, it controls the tumor radiologically better. Some people look at this data and say that's a strong rationale to give radiosurgery to every incidental meningioma, but I think you need to interpret the data more cautiously, given that the neurological event rate was the same in both groups. So what are the bad aspects of looking after people with meningioma? Well, we still need to operate. Obviously, we do this as a shared care decision, and surgery is the first-line treatment for the vast majority of symptomatic meningiomas or growing meningiomas. And you try and optimize, you try and focus your surgery or your treatment approach depending on location and the patient's other medical conditions. What do we get from that surgery? Well, removing the meningioma is generally always good. It takes that mass out of the brain and it provides us with that tissue that allows us to characterize the tumor and to do further research on the tissue samples. And for some people with meningioma, that is genuinely curative. There's a move in various European centres and in North America to start introducing dotatate PET. This is by no means standard practice in the UK, but this is using nuclear medicine imaging to try and determine the extent of bone involvement, particularly useful for meningiomas down at the base of the skull. And in fact, data from the Munich group has shown that even when the surgeons think we've taken it all out, when you do post-operative PET scans, if you see a dotatate signal, those are the patients you can predict more accurately that you will get recurrence. So as I say, not standard in the UK, but something that's being used in other healthcare settings. How we operate has changed. I know there's a couple of surgeons online, some of whom are trained, are slightly older than me and had training in the earlier days of neurosurgery, when skull-based surgeons would try and do more radical or more aggressive surgeries. I think that era has largely gone, and what your surgery is aiming to do now is take out the tumor and do it safely whilst you're minimizing risk to nerves, minimizing risk to blood vessels, minimizing risk to the adjacent brain. But in the past, people would sort of try and reconstruct the major venous sinuses across the top of the head and would report these, quite significant risks. So a 3 in 100 chance of dying from that surgery or a 1 in 5 chance of major morbidity, and suggesting that these might be considered acceptable outcomes or acceptable risks for effecting a cure for the patient. I'm not sure that's true anymore. And certainly people have moved well away from that. Some people are doing planned operations where you can try and do clever things with your radiotherapy planning pre-surgery to say how much would I need to leave to reduce, to provide a sensible dose of radiation that doesn't risk those other brain structures. But surgery does have harms. So if you look at the broader aspects of meningioma surgery, looking at across all aspects of the disease, up to 1 in 5 people may develop seizures in the long term. You lose your driving license, you need time off work. And we can certainly potentially make our patients have a worse quality of life from surgery. Of course, the contrast is that if you've got a big lump in the brain, if you're leaving it there is equally not a good idea more often than not. When we reoperate on patients, when we get recurrence, this is a study we did in Liverpool, just looking at a very crude measure of how well people are. So performance status, are you fitting well? Are you able to look after yourselves? We found that when we did second and third operations, you had a slow decline in people's performance status and ability to look after themselves. And that makes sense because every treatment you do for the brain is in effect giving you a sort of controlled brain injury from which your brain has to recover and may not fully recover. When we take our meningiomas out, we tend to follow people up with scans. When we've done our, not been able to take it all out completely, when you look through the literature, no one's really looking at how quickly these tumors regrow or at what rate they regrow. So in this study, we looked at our subtotally resected meningiomas and did volumetric analysis and tried to get an idea of how quickly they grow. And actually, the growth rate is quite small. So only a 4% growth rate over each year, and quite a small volume of growth that we saw. So just because you get regrowth doesn't mean you need to jump in with your second round of treatment. You can quite readily monitor these individuals. And again, we looked at what we did, and for the majority of patients that we saw progression, we still continued to monitor and didn't necessarily require further intervention. This comes up regularly amongst the clinicians. How frequently should we do MRI scans? And how long should we do them for? There are still no clear guidelines, and I have no sensible answers to this, other than to sort of individualize it for patients. So older individuals in their 80s and 90s, I would suggest are unlikely to need long-term follow-up because they'll have other risk factors for longevity. There are no predictive imaging biomarkers. No one can tell you on the MRI what the grade of the tumor is going to be, despite people trying. So I don't believe the radiologists if they tell you that they can. But people are trying to do cleverer things with imaging and meningiomas. I don't claim to understand how radiomics works, but essentially it's using the data behind the pictures that we see to try and look at different characteristics and different features that might help us predict the grade of the tumor. We've done a little bit of work doing segmentation, automatic segmentation of imaging. If you could automate the image segmentation and volume calculations, that would take a huge amount of work out of the radiologist's hands. And our data showed that this segmentation technique was pretty accurate compared to a radiologist reviewing them. But it would require a lot of effort to put that into routine practice. So just moving on to the ugly or the clinically aggressive ones and why we do clinical trials in this particular area. This is what I was challenged with when I started in this particular area. Why are you looking at this benign pathology? It's benign, it's not that interesting. But actually, when you get into the literature and when you meet with patients, you realize that not all meningiomas stay away and can be cured with surgery, and there is a recurrence rate, which means people need additional new treatments. This is from my colleague in Cambridge, Tom Santarius, who showed me this patient of his who had this horrible grade 3 malignant meningioma that he took out, did a nice operation, and then 6 months later, the tumor is back everywhere in the brain. So fairly upsetting for you to have to look after those individuals, and obviously very devastating for that patient and that family. So we get onto trials, and that's what most of the trials are trying to address: how to optimize treatment, how we manage our patients. And generally, the trials have been split into looking at how to manage the disease early in its course. So after we've had surgery, what is the role for radiotherapy in various meningioma groups? And then at the very end of the disease course, this is people with recurrent or very progressive meningioma for which there are no further surgery or radiotherapy options, and then people using various drug compounds, drug agents to try and develop drugs or investigate drugs that will help these patients. If you look online on the clinical trial databases, you'll find a whole raft of trials out there. So there's people looking at using these drug trials. What you'll notice is that most of these drug trials are in North America. They're single center studies recruiting small numbers of patients. And then if you look at the radiotherapy trials, again, these tend to be a lot of North American studies. Some of them slightly larger. This one, for example, trying to use a multi-session radiosurgery for large meningiomas rather than surgery, it seems. So there are trials out there, there are studies out there. If you're going to do trials, you need to measure the right outcomes. So we all know that we will measure progression-free survival, when did the tumor regrow, and overall survival. Overall survival perhaps less helpful in people with meningiomas, particularly given how long people can live with this disease. So it's controlling the disease and preventing recurrence that's perhaps a more useful outcome for them. There's obviously lots of morbidity that I've already mentioned, but there's no common language of how we describe that or what we report. So we did a project called COSMIC. This was defining what we call a core outcome set. So this is trying to say what outcomes should we be measuring in a clinical trial that should be reported in all clinical trials of meningiomas. And we looked at what would be the core outcomes for observed meningiomas. This process involved several Delphi surveys and a consensus meeting to come up with this list. So a lot of cognitive functioning and role functioning for people with incidental tumors, and that perhaps reflects the anxiety and health uncertainty that these individuals have. And then for interventions, people who require surgical or radiotherapy or drug treatment for their meningiomas, less concerned about those role functioning issues. So these were less relevant for those individuals. So this work has been completed. That paper has been written up, it's been presented, and hopefully this will form the core outcomes that people will measure in all future trials. I'll just show you a few highlights from the radiotherapy literature that are out there. So this is a nice European study, phase 2, a single-arm study looking at giving radiotherapy to completely resected grade 2 meningiomas, showing or reporting rather a good control rate. Limitations, of course, they only looked at 3 years, and really a lot of meningioma growth occurs at 5 to 10 years plus, but promising to suggest that radiotherapy may work. The North Americans did almost identical trial, and again showed good control if you give radiotherapy to grade 2 meningiomas. The North Americans also looked at their low-risk group of patients. So these were the grade 1 meningiomas, and their data suggests that actually maybe we should be considering some radiotherapy post-operatively in those individuals where further surgery is not ideal or not desirable. From Liverpool, we're leading the Rome study. So this is radiation versus observation for atypical meningioma. This is a multi-center international study. Some of you have recruited into this study, for which we are extremely grateful, or you may have participated in this study. And this is really comparing radiotherapy after surgery to active monitoring. The trial is now closed, and we're hoping to get those readout of those results in 2026. What I can share with you is that this trial had a quality assurance of the radiotherapy that was delivered by our clinical oncology colleagues across all sites. So every oncologist had to complete the benchmarking or dummy run cases. So we gave them a recipe book and a manual. This is how we would like you to contour and outline and plan your radiotherapy. What you can see is that even though you give people a recipe book, a small percentage still can't follow the recipe book. So we had to send those back and get them to do it again. And even more worryingly is that when you did it and people were on trial, there was a higher rate of people not being able to follow the recipe book. So again, we had to send those back, and get the oncologist to do it again. However, at the end of the trial, every patient had radiotherapy delivered according to the guidelines and the recipe book that we provided. So what that essentially means is that regardless of the outcome of the trial, we cannot blame poor radiation technique if there's no difference or if there is a difference. So the radiotherapy was highly homogeneous and well delivered. Just to say that North Americans are doing an almost identical trial. Good news for us in Europe and Australia is that they're a couple of years behind, so we're going to beat them to the punch with this trial results. So that's good for us. Okay, what's going on in the drug world? Just to tell you a few bits of data. This has already been published, and these slides are courtesy of Matthias Preusser. And this was a study looking at trabectedin. So this is a compound that has some effect in sarcoma. And they saw in laboratory work that it seemed to have some impact on meningioma cells. And so they randomized people with late-stage meningioma to have trabectedin or local standard of care. And many of you will know this, but the compound did not improve tumor control rates. Sadly, it did not make people live any longer. What they did find is that in the standard of care arm, there were a small number of patients who received bevacizumab, and they are querying whether there was a small signal here and maybe people will benefit from bevacizumab, and they're trying to do a trial potentially looking at a bevacizumab type agent to see if that will help, and it should be tested in future trials. One thing that was a good outcome from this study is that it shows that the study recruited really well and ahead of target. So there's nothing out there for people with these tumors, and so if there's a study open testing a new agent, people will go into that study because there's nothing else for them. What about precision medicine trials? So that's sort of a sort of not quite an old-fashioned cytotoxic, but it's a sort of targeted trial. But what about precision medicine? So about 10 years ago, there was a raft of papers came out. A lot of people have done some work looking at the genetics of these meningiomas and defined a whole series of mutations that were driving the growth of these meningiomas. And the majority of these mutations were in skull-based meningiomas. And then you had these occasional case reports coming out, trying these drugs. This is a AKT inhibitor, and people say, oh, look, it seems to control the tumor. So let's think about doing drug trials in this particular area. These slides are from Priscilla Brastianos. So she is an oncologist at Harvard, and she's running this trial, the Alliance trial, and they're doing this as a platform trial. So they have a series of arms in this trial. People with progressive meningiomas. This is a North American only trial. They come into the study, they'll get their tumor sequenced, assessed for eligibility, and then depending on whether they have, which genetic mutation they have, will depend on which trial arm they may go into. So the data I've got in this talk is for the FAK inhibitor, and I'll also show you the data for the CDK and NF2 inhibitor. So first of all is the FAK inhibitor. So what you can see is they had to screen a lot of people to find a small number with an NF2 mutation. That's the commonest mutation. So they filled this arm up very quickly. They had a mixture of grade 1 and grade 2 and 3 meningiomas. And what they showed was that the drug seemed to have a benefit in terms of progression-free survival and progression-free survival at 6 months. And so what they proposed and was written up was that this compound here was worth further evaluation. An update from their group said that GSK had actually withdrawn this compound and weren't putting it into trials anymore. So they're still looking for other FAK inhibitors, I understand, but it won't be this particular compound, which is a shame. This data was just presented at ASCO 2024. These are not the official slides, but I've used the previous slides just to highlight this particular arm. And this is available on the ASCO website on the abstract. But it basically shows that this compound here, I won't try to pronounce it because I'm not a medical oncologist, but it had good tolerability. It met the primary endpoint, and it seems to be worthwhile, and therefore probably needs evaluating in a randomized fashion compared to standard of care. So 2 compounds there that may hold some hope for those particular patients with NF2 or CDK mutations. Okay, so what's in setup just in the last 5 minutes? So just in Liverpool, we're doing this trial called STOP'em. So this is looking at seizure prophylaxis in meningioma patients. Seizure prophylaxis is very commonly given by surgeons, even though we don't know whether it works. So we're just doing a very straightforward, pragmatic trial comparing 2 weeks of prophylaxis to see if it reduces the risk of developing seizures. It's due to open later this month, and we're looking to recruit over 1,000 patients into this study, which is a very straightforward comparison design. This is a study coming out of the EORTC led by Natalie Alport, who is a nuclear medicine physician. And they're looking at effectively weaponizing dotatate. So using lutetium, I think it's called, and comparing that to a control arm, which are allowed to give whatever you consider a standard of care in your institution. Again, trying to see whether that dotatate PET that I showed you earlier in the talk, if you can weaponize that, will that effectively treat these tumors where there's no more local treatments for them. Some centres in the UK are involved in this, I think. What's the future of meningioma trials and how can we help our patients? So we've moved beyond just the WHO grade, although that's still used for diagnostics. About 5 years ago, this was a great paper, came out of the Heidelberg group from Felix Sam. They're using the Heidelberg methylation classifier to really work out which groups people fit into. So what they found with this is that even though the pathologist can think that something's a grade 1, grade 2, or grade 3, it doesn't necessarily match with their risk of regrowth. So I can show you here, this is a kind of plastic tumor that looks down the pathologist slides as a malignant, but is actually benign. And then you get benign looking tumors that actually turn out to behave more aggressively. And it allows you to separate people out and predict their recurrence rate more accurately. So it allows us to prognosticate a bit more. It's not particularly helping with treatment at the moment. This is just showing that different types of tumors in different locations tend to fit into different types of categories. They're not the only ones. The group in Toronto have developed something. Boston have something similar using copy number variation. And David Raleigh's group in San Francisco are using a gene fingerprint to predict response or sensitivity to radiotherapy. So all these groups are out there looking at these things and trying to design trials around their biomarker. There's lots of potential systemic treatments we could try. Here's just a nice review showing lots of pathways that could be targeted. But essentially what you really need to do is try and integrate all that data, something I coined as meningiomics. It's not taken off, so it can't be that good a word. But essentially what you really want to do is take all this data, take all that biological data, and if they come out as low risk, you should just be monitoring those individuals. But if they are higher risk individuals, you should be having plausible drug targets or plausible driver mutations that you could target, potentially with or without radiotherapy. That's up for discussion. But essentially, this is the only way you're going to improve the outcomes for patients and optimize management for patients with meningioma. So just to conclude, It's a highly heterogeneous disease, even though the guidelines lump them all together as one thing. And that future trials are going to be precision driven or biomarker driven, really to improve quality of life. It's not just me doing this. There's a whole group of people who dip in and out of the research group, from intercalating medical students to academic trainees. So thank you for having me, and I'm happy to take any questions.
Thank you, Mr. Jenkinson. That was really, really interesting. And I do like the new word, Meningioma. I can't even pronounce it, but it's one for the English Oxford Dictionary. So good on. So anyone got any questions? I'll take, if you want to put it in the chat, feel free, or if you want to unmute, put your hand up. And if not, I've got plenty, so. I'll let you go.
So, Mike, thank you for the talk. I thought it was really good. I suppose one of my questions is, if we use integrated risk scores to better predict what happens to patients, how do you think that's going to interpret the evidence, for example, that we've got from, or that we will get from the Rome trial and from similar trials? Because, and this is quite common in medicine, we have to categorize things based on the technology at the time. Then we run a trial, and of course the classification changes partway through. So what are your thoughts on how we deal with that?
Yeah, so that's a very good question. So when we analyze the Rome trial, we are going to analyze it according to the pathology diagnosis in use at the time and report it as per how the trial was designed, because that's what the purists, the trial methodologists, say you will do. We have then got planned several translational papers. So we are working with Heidelberg, Toronto, and UCSF to integrate their predictors into the data and produce a series of papers that say, how relevant is the Rome trial data? Do these new molecular markers allow you to classify it better? Can you pick out better people who will respond or don't respond? So that's what we're going to do. And you're right. So future studies are going to be tricky. It's difficult, isn't it? Because in order to use the biomarkers, none of which are validated, you need to run a trial to validate them. But then you'd say, well, how can you ethically validate them? How can you ethically put them into a trial if they're not validated? You can't. You're in a it's a no-win situation.
Thank you. There's a question in the chat. It says, are there any useful meningioma models, i.e. mice models?
Oh, okay. I think that's Sean Lawler, formerly in Leeds and now somewhere in the US, I think. He may answer on the chat. Not brilliant models. So there are groups who are using mice models. Meningiomas are really tricky to grow in mice. Better models are there are some dogs who are prone to meningiomas that some groups are using to investigate. They're not deliberately giving the dogs the meningiomas, but when they turn up to vet schools, they're looking at these dogs. So yeah, we don't have any brilliant models for meningiomas, is the short answer. But then do we have any brilliant models for any other brain tumors, I would argue? Probably not.
Thank you. I just had one question around the quality of life. So you said that's a really big thing in meningiomas, and it does impact decision making. But the quality of life was in both the bad of doing surgery, but then also in not doing surgery. So how do you come up to that decision? And then are there trials that are going to be focused primarily with the primary outcome on quality of life and then comparator with surgery earlier on versus surveillance or vice versa?
Yeah, that's a very good question. I mean, I suppose so. The quality of life data, I think, is very useful and important for reassuring the people with incidental asymptomatic meningiomas not to have treatment, not to be pushing for some form of surgery or some form of radiation treatment, and that reasonably monitoring them is best for their quality of life and avoids harm. If they need treatment in a future time point, if it becomes symptomatic, then that's okay. For the larger meningiomas that are already symptomatic, you end up having to treat them. You are able to counsel people better and say, we know that it might cause fatigue, chronic headaches, etc., etc. But then you can tailor your support network afterwards towards those symptoms. So you cannot necessarily avoid that harm, but it allows you and the patient to make a much more informed decision. Oh, someone's put a great question.
Yeah, exactly. Do you want to read it aloud or do you want me to read it?
Yeah, so in the chat, when monitoring women with grade 1 meningiomas on active surveillance with slow growth, would you consider impending menopausal status, expect to slow this growth, i.e. push you further away from intervention? Yeah, so the whole menopause and hormone replacement therapy and contraceptive pill and things like that, there's been quite a lot of press recently about this. Most of the hormone replacement therapy that's used in the UK, the doses of those compounds are much lower, and so we don't tend to see growth in meningiomas with people on HRT. The exception to that is cyproterone acetate, which is used by people people transitioning for transgender, and they have much higher doses, and that will definitely drive meningioma growth in those individuals. There was a nice study published recently from a French epidemiologist, I think, in the BMJ, again showing, and that's because the doses of in the hormone replacement therapy of the progesterone compound is much higher, and so you see much more growth in those individuals in French people because they're using higher doses of the hormone. I cannot genuinely answer whether that meningioma will get slower as you transition into the menopause.
Thank you. Does anyone else have any questions? If you don't want to put it in the chat, you can turn your on mute as well. I've got another question, sorry.
Sure.
What are the risk factors, or are there any evidence around those people who get meningiomas except for NF2, those that are more prone to getting more meningiomas, or I can't pronounce the word for multiple meningiomas, and the prevalence of them being difference in grading within them?
Yeah, so multiple meningioma are fortunately less frequently seen. The main risk factor is prior radiotherapy, particularly in childhood. The management of those individuals is very personalized, so you're treating the symptomatic lesions. You need to really plan carefully surgical approach, technique, to when you might give radiation or not. But that's a sort of chronic disease management with a long course for that patient and careful planning. But minimizing your requirement for inputs, treatment is good in those individuals because they're going to need a lot over their lifespan. Yeah.
Thank you. I think we've got time for 2 more questions if anyone's got any. Yeah. Matt?
Michael, when I know this may not be kind of entirely your area, but you were talking about the lutetium dotatate study. And I think it's very good they're doing a trial of it, but we have used lutetium dotatate before in a non-randomized setting, and I would suggest without any stunning results.
Right.
Do you know, and you may well not do you know if they've done much dosimetry to show how much dose you actually get into the tumor when you give lutetium dotatate?
Yeah, no, that's a good question. So I don't know the answer to that, but the North Americans are running a similar study. And I can't recall whether they've looked at dosing, how much gets in there, etc. Yeah.
And then the other, and again, this is a very technical aspect. So when we have people with very large or quite large meningiomas, one of the things that we've sometimes done is irradiated a sub-volume of the meningioma, and it allows you to give a high dose of radiotherapy without giving a substantial dose to the brain. And certainly Christa Lindquist used to argue that really what you were doing when you gave stereotactic radiotherapy to meningiomas was damaging their vascular supply, and that therefore you didn't need, these are benign diseases. You don't, unlike a metastasis, you don't need to treat every cell because you're not worried in the same way. I don't know. I've never seen that published in any formal context, and I didn't know if you'd ever seen anyone study it.
No, I mean that's it's a good technical question, a good point, isn't it? I mean, what's very often you don't see much in the literature about these large non-surgically treated meningiomas or large surgically treated meningiomas with still a large residual, and what dose, how should you treat, where should you treat? It's a good point. You know, it's not a invasive disease like by and large, like metastases and gliomas. So yeah, killing the middle of it so that it affects the blood supply and just stops growing is probably a reasonable approach. Sounds like there's a trial in there somewhere, Matt.
Yes, there is a trial in there, but it's a challenging
That's
trial
a
to
bet. Yeah, that would be very challenging technically
However,
to deliver.
at the British Radiosurgery Society meeting in January next year, which is in Birmingham, that may be one of the things we want to discuss.
Great, good stuff.
Thank you again. Does anyone have a final question before we wrap up? Well, I'll take silence as no. So thank you, and thank you again, Mr. Jenkinson. That was no.
Sorry, no, that was great. Lily, sorry. After you finish, can I say something really briefly?
Sorry. Yeah, no, thank you again, Mr. Jenkinson, and thank you for offering to do this again after last time being caught up in the theatre, probably operating on one of these meningiomas. So thank you again. And I think everyone in the audience wants to say a big thank you. So
thank you very much.
No, thank you, Mark. That's really good. And then just a final note on HIN sessions. We are going to try and squeeze a HIN session in early July, because obviously then we run into the summer. There's the BNOS meeting and everyone goes away. If we can't squeeze a HIN session in early July, then we'll pick it up again in mid to late September, so that we give everyone a summer break, and hopefully I will see many of you there. Thanks very much.
thank you.